Before the main part of the podcast, I would like to give a little shout out to the University of Hertfordshire, who are doing a doctoral study on something that is often overlooked in academia. They're conducting research into the experiences of parents or carers who help to look after a child or children where the family has a parent that has mental health difficulties. Now, that is a bit of a mouthful, but what they're looking for are people that are supporting a family where the parent or a parent has a mental health condition and you're supporting their child within the family. And this study is aiming to learn more about the experiences of parents and carers who look after a child or children in the family where the parent has a mental health difficulty. So, for example, this is if someone has a parent that has been living with bipolar or any other kind of mental health issue. So in this situation, what they're looking for are people such as the partner of the parent who is suffering from a mental health issue, the grandparents, older siblings, aunts and uncles, and so that's anyone that is really providing support to the child who is living with a parent that has a mental health issue. And these people will be often providing emotional support for the child. They may also help out with household chores and so forth. And these people are really important to the family and supporting the family generally. However, there's been a lack of research done on this area. So the guys at the University of Hertfordshire are looking for people who are looking after a child or children aged 4 to 17 with a parent that has a mental health difficulty. So this could be officially diagnosed or it could not be. So it doesn't really matter if it's diagnosed or not. Participants are expected or should be willing to take part in an interview with the researcher to talk about your experiences. And what will happen is that it will go into the larger study for the researchers to find out more about how your support is impacting the family and yourself. If you are willing to help out in this research, you will be asked to take part in an hour-long interview, and this interview and its location is generally flexible depending on your individual needs. And if you are nowhere near Hertfordshire, they can do the interview via Skype with you. So if there's anyone out there that's listening to this podcast and you think that you fit this criteria and you would like to find out more about how you can get involved with this research, all you need to do is send an email to r.bishop@hearts.ac.uk, or you can tweet at BeccaJBG. I will put all of this in the show notes for you so that if you are interested and would like to participate, you can easily find the information. I think that this piece of research will be invaluable to those that are looking after or helping out a family who has mental health issues ongoing, and you telling them your own personal experiences can help with them supporting other people who find themselves in the situation as well as yourself. So that was just a little bit of a shout out to this research study being conducted at the University of Hertfordshire by Becca. So good luck, Becca, in your recruitment of participants. Hello and welcome to the Mental Health Book Club podcast with your hosts Sydney Timmins and Becky Lawrence. We would like to take this opportunity to let you know that we will be covering a diverse range of mental health topics that may be distressing to some listeners. You can find a full list of the topics being covered in each episode in the show notes. Please check the show notes before listening to any of our episodes. Welcome to this week's edition of the Mental Health Book Club podcast with me, Sydney Timmins. And today we're going to be doing a deep dive into depression and suicide. And at this point, I'd just like to point out that if you find any of these particular topics triggering, this is probably not the podcast episode for you. I would suggest you skip this one and join us next week when we're going to be reading Autism Anxiety and Me by Emma Louise Bridge. I would also suggest that you skip the previous episode on My Heart and Other Black Holes by Jasmine Warger. And I would also suggest that you skip that particular book because I think some people this will be a particularly difficult read. And before we get started on this, I wanted to just say that I am no expert on mental health issues. All of this information I have collected from the internet from various sources, and I'll put all of those sources in the show notes for you so you can find out more information if you so wish. But I am a sufferer from depression, so along with my borderline personality disorder, I have depression and anxiety, and I have been to a point in my life where suicide has crossed my mind, and I have had some suicide attempts personally. So as well as going through some of the statistics and information about what depression is and what suicide is and impacts of all of those. So for me, My Heart and Other Black Holes, although I actually really enjoyed the book, I did find it quite difficult to read. I also felt that perhaps the topic of suicide pacts was a difficult one to digest. However, I do think that talking about suicide and suicidal thoughts can help to remove some of the stigma associated with feeling so desperate in your life that you feel that the only option for you is to end it all. And particularly when I go into the statistics, you'll start to see that certain age groups, so the younger age groups, are more likely to make a suicide attempt than other age groups, and unfortunately end their lives that way. And so I think this particular book is important because it does show, even though they entered into a pact to begin with, that between the two of them, talking about their depression did have a benefit, and particularly for Azel, who starts to feel a lot better about life. But anyway, I digress slightly, so let's get stuck into depression and suicide. And so some of the statistics I have taken from the World Health Organization, the Mental Health Foundation, which has a report about mental health, and also the Office for National Statistics, which is an independent department that reports directly to the UK government about the differences and the information about the UK population in terms of statistics. So, depression, according to the 2013 Global Burden of Disease study, is the predominant mental health problem worldwide. That is then followed by anxiety, schizophrenia, and bipolar disorder. Depressive disorders also contribute to the burden of suicide and heart disease on mortality and disability. They have both a direct and indirect impact on the length and quality of life. In terms of bipolar disorder, which was originally named manic depression before it was changed, the findings from the Adult Psychiatric Morbidity Survey, or the APMS, in 2014 showed that 2% of the population were screened positive for bipolar disorder, and that those rates didn't differ between genders, so men and women were roughly the same, but they did differ between age groups significantly. So, for example, the highest prevalence was between 16 to 24-year-olds, with 3.4% of that 2% suffering from bipolar. And for the older age groups of 65 to 74, only 0.4% of them were considered to screen positive for bipolar disorder. And over the age of 75, it hasn't been identified in that particular age group. One of the impacts of depression can be the fact that people start to feel suicidal. In some ways, it's important to know that if someone is choosing suicide, that there is usually no one particular factor. It's usually as a result of a whole heap of stuff that all comes together and makes them feel so overwhelmed, particularly from my perspective when I got to this point, that you feel like that is the best way out of it, that you are in so much pain that you want it to stop. There are certain things that will obviously impact whether you have suicidal thoughts or not, such as having mental health problems. So for me, it probably was the fact that I was suffering with depression and borderline personality disorder that hadn't been diagnosed at the time. Also, the fact that some people may find that they feel suicidal as a result of alcohol or other substance misuse, and that individual feels hopeless and helpless, and as I said, like it's their only way out and their only option. People who have self-harmed or made a serious attempt at suicide in the past are more likely to try so again, and are therefore at much greater risk of dying by suicide in the future. And so it's important that we are sensitive when we discuss suicide and the topic of suicide. And I found this fantastic resource on the Samaritans website that specifically aimed at the press and people who talk about suicide and the things that people should potentially avoid to reduce the risk of someone going out and acting on the information that they have provided, particularly when it comes to celebrities who may have made a suicide attempt and have resulted in taking their own life. But the information provided by the Samaritans had information about how we should talk about it, the things that we should say, and how we should speak about it. So I must confess, listening back to mine and Becky's discussion on My Heart and Other Black Holes, we probably used some language that wasn't necessarily the most conducive. So for example, it is recommended that you don't use the term commit suicide, but instead you use terms such as a suicide, the taking of one's own life, they have a person at risk of suicide, die by or death by suicide rather than commit suicide, a suicide attempt, and a completed suicide as all terms that are better than certain other terms. And so I would like to say, if we caused any offence to anyone out there, we apologise. But from my own personal experience, I don't necessarily think that I would be influenced by someone else talking about suicide, because I'd already got to the point where I was, in some ways, had made a decision to do something. The Samaritans also recommend that whenever possible, so if someone is talking about suicide, that you try to refer to the wider issue associated with suicide, such as risk factors like alcohol misuse, mental health problems and deprivation, and that you also consider the lifelong impact that suicide can have on those bereaved by a suicide. Discussion of such issues can encourage a better understanding of the topic. So for those that are left behind after someone has attempted suicide or had a completed suicide, it can be extremely devastating. And whilst I haven't necessarily been in that position, I definitely have spent some time contemplating what it would be like for others around me if I had taken my own life. Also, there probably was a pattern of behaviour that people around me could have seen beforehand, particularly my husband, because he's the one closest to me. But some people considering suicide may hint or even declare to friends or relatives that they intend to take their own lives, and other people who are feeling suicidal might not mention it at all or give any indication of their intention. And so there is this importance that people who are around you may then blame themselves later because they didn't necessarily pick up on the signs. It is also thought that, or it is shown in research, that inappropriate reporting by the media in association with suicide may lead to imitative or copycat behaviour. So for example, if a vulnerable group, such as people with mental health problems and young people, are provided with details about the method of suicide use, it can lead to more deaths using that same method. So I think perhaps in My Heart and Other Black Holes, when there is discussion about the suicide method that they intend to use, that could be a potential issue. However, I think if that wasn't necessarily discussed within the book, then there would be a major plot hole within the story itself. I think in some ways it is critical for the story. However, I think maybe the book, I read it on Kindle, should have more of a trigger warning associated with it somewhere, just to ensure that people who are vulnerable are not necessarily reading this book. However, as I said before, I want people to talk about this. I want people to know that having suicidal thoughts is not necessarily a bad thing. What is more of an issue is acting on those suicidal thoughts later on. There's also evidence that a vulnerable person who might not otherwise have attempted suicide could strongly identify with a particular characteristic of a person who has died from suicide, and this may lead them to take their own life. So for example, within the book, there may be some association that people will recognise characteristics within Azel and Roman, and as a result of that could then go out and try and take their own lives. And I think that just generally talking about suicide is complicated in its own right, because as a result of these podcasts, I don't want anyone to try and make an attempt on their own life. What I would really love is that people would feel able to open up and talk about how they're feeling. In 2016, 5,668 suicides were recorded in Great Britain. And I think what is the most scariest part is that 75% of those were men and 25% of those were women. So it is higher in the male population. There's probably a variety of factors that could impact this particular number. But for me, I think one of the biggest things that could contribute to that number and that scary number is the fact that we socialise men to be tough and not to discuss emotions. And as a result, they may keep things bottled up and feel that their only way out is to attempt suicide. Between 2003 and 2013, 18,220 people with mental health problems took their own life in the UK. Suicide is the most common cause of death for men aged 20 to 49 years in England and Wales. And 1 person in 15 had made a suicide attempt at some point in their life. The suicide rate in Scotland rose by 8% between 2015 and 2016, with 728 suicides registered in 2016 in Scotland. As I said at the start of this podcast, that the rates among men are a lot higher than they are among women, and this is similar on a worldwide scale as well. But worldwide, 800,000 people die due to suicide every year, and that equates to 1 person every 40 seconds. Many more attempt suicide. There are indications that for each adult who died of suicide, there may have been more than 20 others attempting suicide, which I find extremely distressing. And suicide occurs throughout the lifespan and is the second leading cause of death among 15 to 29-year-olds globally. And suicide is a global phenomenon. In fact, 78% of suicides occurred in low and middle income countries in 2015. Suicide accounted for 1.4% of all deaths worldwide, making it the 17th leading cause of death in 2015. The World Health Organization states that effective and evidence-based interventions can be implemented at population, subpopulation, and individual levels to prevent suicide and suicide attempts. Also associated with depression is self-harm, and at this point I will also say that I have self-harmed in the past. I have been self-harm free since 2013 and it's now 2017. It took a lot for me to stop self-harming, but it's been probably one of the better things that I've done in my life. But unlike the case of suicide, the statistics associated with self-harm are actually less reliable. And unless someone admits to a GP or talks to a GP about it, which I don't know about you guys, but the stigma associated with self-harm actually made me consider whether I should disclose the fact that I did it or not, particularly because of the stigma and the fact that they would just label me as a completely mad person. I didn't tell them until I'd been self-harming for maybe 20 plus years at the point I declared it. But the reason why people don't necessarily declare it, and the reason why we have limited statistics on this, is because we can only really count the hospital admissions that are as a result of self-harm, and we classify self-harm as an intentional self-harm. And so 90% of those that are recorded in hospitals of intentional self-harm have appeared because they have tried to self-poison themselves. But as I said before, not all self-harm leads to hospitalisation. I mean, I never was hospitalised as a result of my self-harm. And so that obviously will change the statistics that we see. So the number of hospital admissions due to intentional self-harm has been rising over the last decade. So between September 2005 and August 2006, it was recorded at 91,341 admissions to hospital for self-harm. And between September 2014 and August 2015, it has increased to 112,096. But what is interesting to note that actually there has been a decrease. So in the year 2013 to 2014, there was a decrease of 1.8%, where in 2013 to 14, 114,105 people were admitted for self-harm. And of those, 69,800 were from female admissions, and 42,282 were from male admissions. In terms of all admissions, women and girls comprised the majority at 62% of the admissions for intentional self-harm. So worldwide, it is thought that there are more than 300 million people affected by depression. And what is interesting or important to note is that depression is different from usual mood fluctuations and short-lived emotional responses to challenges in everyday life. So some people may use the term, "Oh, I'm so depressed today," really in the wrong context, and all they're really feeling, it's not necessarily all they're really feeling, but they have a low mood. and that after a short period of time their mood will lift. However, when we're talking about depression, we're talking about something that is long-lasting. It's a prolonged feeling of low mood, and it can increase to a moderate to severe intensity, where it can then be classified as a serious health condition. It can cause the affected person to suffer greatly and function poorly at work, at school, and in the family. At its worst, depression, as we've said, can lead to suicide, and close to 800,000 people die due to suicide every year. And suicide worldwide is the second leading cause of death in 15 to 29-year-olds. Again, this probably highlights the importance of people talking about suicide. Yes, there is this concern out there that people that are contemplating suicide and read something about it will more likely attempt a suicide than they would if they hadn't read anything about it. But from my personal perspective, I don't think that when I was that low, just reading about it would have urged me on to attempt suicide. I think I was already there, and I don't think it would necessarily have given me ideas to go ahead and do anything. But for some people, it may cause triggering emotions, which then prompt them to act upon them. So I guess it's a pretty difficult line to toe as to whether we talk about suicide more openly. And I think particularly in that age group, the 15 to 29-year-olds, that reducing the stigma for them to talk openly about mental health could help reduce the numbers of people attempting suicide. And although we know that there are effective treatments out there for depression, worldwide, fewer of half of those affected will seek or receive treatments. And in some countries, as few as 10% receive such treatments that have been shown to be effective. And there are a whole host of barriers that are there that may stop people from seeking effective treatment. And that includes lack of resources. So although I probably complain quite a bit that the UK has a lack of mental health provision, it is worse for other countries out there. So in some ways we are still pretty fortunate. There's also this lack of trained healthcare providers. And also the social stigma associated with mental disorders can impact people identifying that there is an issue and going and seeking help. In countries of all income levels, people who are depressed are often not correctly diagnosed, and others who do not have the disorder are too often misdiagnosed and prescribed antidepressants, which is another concern, is that are some practitioners jumping the gun a little bit and putting everyone onto antidepressants, or if they are potentially misdiagnosing it and just leaving someone who is very depressed to continue with their lives and may impact their day-to-day living and their quality of life and how they respond to emotional issues. Research also shows that the burden of depression and other mental health conditions in general is on the rise globally, and the World Health Assembly resolution passed in May 2013 has called for a comprehensive, coordinated response to mental disorders at country level. And I guess in some ways you've got to consider whether it's actually a case of that the number of people with mental health conditions are rising, or is it just that we're getting better at recognising them and diagnosing them and doing something about them in our populations. So signs and symptoms of depression. These include tiredness and loss of energy, sadness that doesn't go away, a loss of self-confidence and self-esteem, difficulty concentrating, not being able to enjoy things that are usually pleasurable or interesting, feeling anxious all the time, so depression is usually seen in conjunction with anxiety, avoiding other people, sometimes even your close family and friends, feelings of helplessness and hopelessness, sleeping problems, so that's difficulties getting to sleep or waking up much earlier than you usually do, or even the opposite and you just can't get out of bed, very strong feelings of guilt and worthlessness, finding it hard to function at work, college and school, a loss of appetite or the opposite, binge eating, a loss of sex drive and or sexual problems, physical aches and pains, thinking about suicide and death, self-harm, And also some people with depression may experience psychotic symptoms such as hallucinations, which is the hearing of voices, or delusions such as paranoia. And these are often linked to your depressive thoughts and feelings, but that is a possibility that you may experience those without the presence of psychosis and schizophrenia. And if you experience 4 or more of those symptoms for most of the day, every day, for more than 2 weeks, you should go and seek help from your GP. And I have found a Nhs Depression Questionnaire that you can do online that gives you an indication as to whether you are currently depressed or not. So I thought, because I have experienced depression and I take antidepressants, that I would give it a go. And I actually came out really low, which was quite a shock in some ways, but also quite positive, because it's showing that the antidepressants for me are working, and also the fact that I'm in therapy is working for me, and that I potentially am feeling better than maybe I would think I am. Anyway, there are different types of depression. There's mild depression. Now, when I looked at the different types of depression, there's quite a lot of conflicting information out there, particularly in terms of what it is that they're calling the different types of depression. So mild depression, or dysthymia, or chronic depression, all of those are now kind of under a particular disorder called persistent depressive disorder. And so that's the new classification within the DSM-5, which was released in 2013. So someone who is suffering from PDD, or persistent depressive disorder, has a continuous long-term chronic form of depression, hence why chronic depression has been put under this particular umbrella term. And a person experiencing PDD may find that they lose interest in normal daily activities, feel hopeless, lack productivity, and have a low self-esteem and an overall feeling of inadequacy. And these feelings can last for years and may significantly interfere with their relationships, schoolwork, and daily activities. So for a diagnosis of PDD to be made, the individual needs to meet the following criteria. Criteria A, the person needs to report a depressed mood for most of the day, for more days than not, as indicated by either subjective account or observation by others, for at least 2 years. For children and adolescents, mood can be irritable and the duration must be at least 1 year, so it's a little different for younger people. Criteria B, there needs to be a presence, while depressed, of 2 or more of the following indicators: poor appetite or overeating, insomnia or hypersomnia, low energy or fatigue, low self-esteem, poor concentration or difficulty making decisions, feelings of hopelessness. So any 2 of those, but it can be more. Criteria C, during the 2-year period, or 1-year period for children and adolescents, of the depressive disturbance, the individual has never been without symptoms in criteria A or criteria B for more than 2 months at a time. Criteria D, for a criteria for a major depressive disorder, may be continuously present for those 2 years. Criteria E, for the individual there has never been a manic episode or a hypomanic episode. The criteria has never met cyclothymic disorder. Criteria F, the disturbance is not better explained by persistent schizoaffective disorder, schizophrenia, delusional disorder, or other specified or unspecified schizophrenia spectrum and other psychotic disorders. Criteria G, the symptoms are not attributable to the physiological effects of substance abuse, such as drug abuse or medication, or another medical condition such as hypothyroidism. And criteria H, and the symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. So all of those criteria are what they're looking for to diagnose PDD. There's also something considered major depression. And major depression interferes with an individual's daily life, with eating, sleeping, and other everyday activities. And some people may experience only 1 episode, but it's more common to experience several episodes in a person's lifetime. And this can lead to hospital admissions if the person is so unwell they're at risk of harm to themselves or even others. So for someone to be classified as having major depression, they need to fit the criteria. So criteria A, for a person to be classified as having major depression, they need to fit 5 or more of the following symptoms. and these symptoms need to have been present for the same 2-week period and represent a change from previous functioning, and at least one of the symptoms is either 1, depressed mood, or 2, loss of interest or pleasure. So 1, depressed mood. So the individual has a depressed mood most of the day, nearly every day, as indicated by either subjective report, so they tell you that they feel sad, they feel empty and they feel hopeless, or observations made by other people. 2, markedly diminished interest or pleasure in all or almost all activities most of the day, nearly every day. And this can be indicated again either subjectively or from observations by others. There's significant weight loss when not dieting or weight gain, so a change of more than 5% of body weight in a month, or decrease or increase in appetite nearly every day. 4, insomnia or hypersomnia nearly every day. 5, psychomotor agitation or retardation nearly every day. This is observable by others and not merely subjective feelings of restlessness or being slowed down. 6, fatigue or loss of energy nearly every day. 7, feelings of worthlessness or excessive or inappropriate guilt, which may be delusional nearly every day, and that's not merely self-reproach or guilt about being sick. 8, diminished ability to think or concentrate or indecisiveness nearly every day, either by subjective account or as observed by others. 9, recurrent thoughts of death, not just fear of dying, recurrent suicidal ideation without a specific plan, or a suicide attempt, or a specific plan for committing suicide. Criteria B. The symptoms cause clinically significant distress or impairment in social, occupation, or other important areas of functioning. And criteria C. The episode is not attributable to the psychological effects of a substance or to another medical condition. There is also prenatal and postnatal or postpartum depression, and so that is women during pregnancy may feel depression, and also once the baby is born may feel depression, and postnatal depression can leave mothers feeling completely overwhelmed, inadequate, and unable to cope with their newborn babies. They may have problems sleeping, they may experience panic attacks, or they may also have intense fear of dying, and they may also experience negative feelings towards their child, and it affects 1 in 10 mothers and usually begins 2 to 3 weeks after birth. There's also seasonal affective disorder, or SAD, and this is associated with the start of winter and can last until spring, when longer days bring more daylight. When it is mild, it is sometimes called the winter blues. However, SAD can make the sufferer feel anxious, stressed, and depressed, and it can also interfere with the moods and sleeping and eating patterns of the individual suffering from SAD. There's also disruptive mood dysregulation disorder, and for this, the disorder is a new condition that was introduced in the DSM-5 to address symptoms that had been labelled as childhood bipolar disorder. Before the DSM-5's publication, this new disorder can be diagnosed in children up to the age of 18 years who exhibit persistent irritability and frequent episodes of extreme out-of-control behaviour. There is also something called Premenstrual Dysphoric Disorder, or Pmdd, and the criteria for this is a little bit more complicated, and so this is now an official diagnosis in the DSM-5, and it is essentially in women in a year period have 5 or more of the following symptoms. And those are, number 1, marked affective liability, so that's mood swings, feeling suddenly sad or tearful, or increased sensitivity to rejection. 2, marked irritability or anger, or increased interpersonal conflicts. 3, markedly depressed mood, feelings of hopelessness or self-deprecating thoughts. Criteria 4, marked anxiety, tension, feelings of being keyed up or on edge. Number 5, decreased interest in usual activities such as work, school, friends and hobbies. 6, subjective sense of difficulty in concentration. 7, lethargy, easy fatigability or marked lack of energy. 8, marked change in appetite, so that's overeating or specific food cravings. 9, hypersomnia or insomnia. 10, a subjective sense of being overwhelmed or out of control. And 11, other physical symptoms such as breast tenderness or swelling, joint or muscle pain, or sensation of bloating and weight gain. And these symptoms generally occur during the final week before the onset of menses, and it starts to improve within a few days after the onset of menses, and where minimal or absent in the week post-menses, with at least one of the symptoms being either 1, 2, 3 or 4. For some people, depression can be a symptom of another mental health issue, such as bipolar disorder, borderline personality disorder and other personality disorders, which is my case, and schizoaffective disorder. And for me, I probably went and spoke to my GP about feeling depression and suicide, and they probably didn't necessarily go into the additional symptoms that I was suffering from. So for me, I definitely probably was misdiagnosed for a long time and was classified as having depression. So it's important if that you are experiencing any other symptoms that you mention those symptoms. So if you can, and you feel able to, explain all of the symptoms that you're suffering, and then you can ensure you get the help that you need. So what causes depression and what are the risk factors associated with developing depression? Well, unfortunately, the research out there is still very patchy on this. There is no clear definitive answer as to what can cause depression or what increases the risk factors, but it's generally a combination of different things. And these include biochemistry, so differences in certain chemicals in the brain that may contribute to symptoms of depression, genetics, so if there is depression that runs in your family, you may be predisposed at developing depression yourself. So for example, in identical twin studies, if one identical twin has depression, the other has a 70% chance of having the illness sometime in their life. Your personality can impact whether you develop depression or not. So people who have low self-esteem, who are easily overwhelmed by stress, or who are generally pessimistic appear to be more likely to experience depression than others. There's also environmental factors, and recently the spike in depression and suicide attempts, etc., may be as a result of the changes in the financial climate that we are seeing across the world, including the UK. So that includes things such as poverty, other medical health conditions, such as those that affect the brain and the nervous system. So the one that springs to my mind, because I suffer from it, is multiple sclerosis. Hormonal problems, especially thyroid and parathyroid problems, symptoms relating to the menstrual cycle or the menopause, low blood sugar and sleep problems. Other mental health issues can impact the onset of depression. Childhood experiences, so neglect, an unstable family life or traumatic events, continuous exposure to violence or abuse, and just general life events such as losing a job, financial problems, end of relationship, bereavement, as just some examples that I can give at the moment. And it's important to note that not everyone who goes through negative experiences in their past may develop depression. It's really how we deal with those negative experiences as to whether we develop depression or not afterwards. And it's about our ability to cope and seek support and get support from others, and how we just generally deal with difficult emotions. So for example, other people that have gone through similar things in their childhoods, as I have, may not develop depression. So there are several treatment options for depression, and it really depends on the type of depression the individual is suffering. So I've taken most of this information from the NHS Choices website, and it splits it into mild depression, mild to moderate depression, and moderate to severe depression. So if an individual presents to a GP with mild depression, you may find that they take the approach of wait and see. So for someone with mild depression, that depression may improve by itself. And if that is the case and that is what your GP recommends, then you should be seen again within 2 weeks to monitor the progress. And this is known as watchful waiting. They might also recommend that you do some exercise, because it is found that exercise can improve depression and mood. And if this is the case, they will probably give you some information about how to get started with exercise, and may also prescribe you exercise on prescription. And I will put some of these links in the show notes for you. They may also suggest that you attend self-help groups, and you can find information about those generally on the Mind website. Your GP may also suggest and recommend some self-help books and online cognitive behavioural therapy. For those with mild to moderate depression, so this is for mild depression that isn't improving with the previous interventions, or moderate depression where your GP has recommended a talking treatment such as CBT or counselling to treat your depression. And this can either be done via your GP, or in some areas of the UK you can self-refer, and obviously this is different in different countries depending on where you are. For moderate to severe depression, the following treatments are recommended for you, and those are antidepressants, which are tablets that are used to treat depression, and there are almost 30 different types of antidepressants available, and they have to be prescribed by a doctor, and usually the depression is moderate or severe. Your GP may recommend combination therapy, and that is a course of antidepressants plus some talking therapy, particularly if the depression is quite severe, and a combination of antidepressants and CBT usually works better than having just one of those treatments alone. If you have severe depression, you may be referred to a mental health team that is made up of psychologists, psychiatrists, specialist nurses, and occupational therapists, and this team often provides intensive specialist talking treatments as well as prescribes medication for you. And in terms of the talking treatments, you could be recommended cognitive behaviour therapy, which aims to help you understand your thoughts and behaviours and how they affect your day-to-day life. With CBT, what it does is it recognises the events in your past and how they have shaped you now, but it concentrates mostly on how you can change the way you're thinking, feeling and behaving in the present. It also teaches you how to overcome negative thoughts, so for example being able to challenge hopeless feelings. CBT is generally available on the NHS for people with depression or any other mental health problem that has been shown to help by using CBT as a treatment. At the moment, CBT is usually for a short time, so that's usually 6 to 8 sessions over a 10 to 12 week period, and it's usually on a one-to-one basis with a counsellor trained in CBT. And in some cases you may be offered group CBT. If face-to-face CBT isn't appropriate or difficult for you to attend, you can also do online CBT, and that is a type that is delivered through a computer rather than face-to-face with a therapist. You'll have a series of weekly sessions and should receive support from a healthcare professional, and online CBT is usually prescribed by your GP, and you may have to use the surgery computer to access the program, and that really depends upon the area that you live in. You could be described something called Interpersonal Therapy, or IPT, and that focuses on your relationships with others and on problems you may be having in your relationships, such as difficulties with communication or coping with bereavement. There's some evidence that IPT can be effective as antidepressants or CBT, but more research is needed, so this is generally one of those treatments that may not necessarily be the first that you're offered. There's also psychodynamic psychotherapy, and with this type of therapy, a psychoanalytic therapist will encourage you to say whatever is going through your mind, and this will help you become aware of hidden meanings or patterns in what you do or say that may be contributing to your problems. And I will put a link to more information about psychotherapy and psychodynamic psychotherapy in the show notes for you. There's counselling as well, and that's a form of therapy that helps you think about the problems you're experiencing in your life so you can find new ways of dealing with them. So Becky has counselling with a counsellor that she pays for independently of the NHS, and counsellors support you in finding solutions to problems but don't tell you what to do. And counselling on the NHS usually consists of 6 to 12 week 1-hour sessions in confidence to a counsellor who supports you and offers practical advice, and counselling is ideal for people who are generally healthy but need help coping with current crises such as anger, relationship issues, bereavement, redundancy, infertility or serious illness. I also found a load of information specifically about antidepressants in more detail, and I shall put that in the show notes for you just because it is quite a lot of information that goes into different types of antidepressants, the impacts that they have on you, plus the side effects and all of that kind of stuff. And so what I will do is I'll put that into the show notes for you to have a look at your leisure. There are also alternative therapies that you could use to treat your depression, such as mindfulness. And I personally use mindfulness quite often. And what mindfulness is it involves you paying particular attention to the present moment. So it's ensuring that you are in the present. So for example, you focus your thoughts and feelings and bodily sensations on the world around you to improve your mental well-being. There are a variety of different mobile phone apps that you can download, and they take you through a guided mindfulness session, and you can do that on a day-to-day basis. And the aim of mindfulness is to develop a better understanding of your mind and body and to learn how to live with more appreciation and less anxiety. Mindfulness is recommended by NICE, which is the guidelines that set out the NHS's treatment plans as a way of preventing depression in people who have had 3 or more bouts of depression in the past. And I'll put some more information about mindfulness in the notes. But for mindfulness, what I generally do is I tend to either do mindful breathing. I also have done mindful walking. So with mindful breathing, I count in for a certain amount of counts and count out for a certain amount of counts with the in-breath and the out-breath. In terms of mindful walking, I would combine the walking with the breathing. So I would walk 4 paces whilst breathing in and walk 4 paces whilst breathing out. I've also done mindfulness with music. So listening to a piece of music and just taking the time to listen to the music and describe what's happening in the music and so on. You may find that during mindfulness that your mind tends to wander, and this is not necessarily a bad thing, and it's not that you are failing at doing mindfulness. What you need to do is then bring your attention back to the moment that you are currently in, and it's normal for things to pop into your head. And the more that you redirect your focus back to the present, the better it is for you, because it stops you from ruminating on different experiences and so on. You can also take a supplement called St. John's wort, which is a herbal treatment that some people can take for depression, and it's generally available in food shops and pharmacies. There's some evidence that St. John's wort will help with mild to moderate depression, but it's not necessarily recommended by doctors. And this is due to the fact that there are many different types of tablets available and they differ in their active ingredients, and then that will change the efficacy of the herbal remedy that you are taking. Also, it's worth noting that when you take St. John's wort with other medications such as anticonvulsants, anticoagulants, other antidepressants, and the contraceptive pill, there's also serious problems that can occur because they interact with each other. So you shouldn't take St. John's wort if you're pregnant or breastfeeding either. We don't know at this moment if it is safe. St. John's wort can also interact with the contraceptive pill, making it less effective. Other treatments for depression can include brain stimulation, and so this is usually used for severe depression that hasn't responded to any of the other treatments that have been prescribed. And so this is where electromagnetic currents are passed through electrodes to stimulate different areas of the brain. And for some people, this has resulted in an improvement in their symptoms of depression. And there are a large number of different types of brain stimulation that can be used to treat depression, included transcranial direct current stimulation and electroconvulsive therapy. And what you may find is that thanks to films and information out there, people may find that using electroconvulsive therapy is very much stigmatized, probably thanks to One Flew Over the Cuckoo's Nest. But although electroconvulsive therapy is the more intense of the different types of brain stimulation, and it has been proven to help certain people out there with their symptoms, and if it helps you improve your symptoms, then you should definitely give it a go. As with all treatments, brain stimulations have drawbacks and side effects. So with all of these different treatments, ensure that you get all the information that you need to make an informed decision about your treatment. Also, in some cases of depression, lithium may be used, and this particular type of treatment is only usually recommended when you've tried other antidepressants and they haven't had any improvement upon your symptoms of depression. So usually lithium is used in conjunction with other forms of treatments and medication. And there are 2 types of lithium. There's lithium carbonate and lithium citrate. Both of those are usually effective for an individual. However, if one of those is proving to be effective, it's probably best not to change that medication. However, one of the major downsides of taking lithium is that if it builds up within your body, it can become toxic. And so you would need to have continuous blood tests every 3 months to check your lithium levels while you're on that particular medication. So if you are living with depression, such as myself, there are several things that you can do to keep you on more of an even keel maybe than at other times in your life. So it's a case of ensuring that you're looking after yourself. Now, I've taken these top tips from Mind, and we have things that they suggest are getting good sleep, ensuring that you're eating well and a healthy diet. So I don't know about you, but generally my mood will reflect how I'm eating. So if I have had a binge on takeaways and unhealthy foods and chocolate, etc., I tend to find that my mood is generally lower. Also, the fact that as a result of eating those foods, I generally then beat myself up for being quite a bit of a slob and not looking after myself. Keeping active, so that's ensuring that you are doing lots of different activities, such as walking and swimming. And it has been shown within research that walking and swimming and doing activities can change your mood. Also, avoiding drugs and alcohol. So for me, the drugs that I take recommend that you don't drink alcohol with them. However, I know that as a result of drinking alcohol, and although there is a period of time where it stops me feeling stuff, when I come down off of the alcohol, I generally feel worse and more depressed. Ensure that you're looking after yourself, so practicing self-care. So try and work out what makes you happy. So for example, doing this podcast makes me happy, hence why I keep doing it. I also love to craft, so I do that. I also love to write, so I also do that. So there's quite a lot of different things that you can do. So work out what is best for you and what makes you happy. Also, treat yourself. When you're feeling down, it can be hard to feel good about yourself. Try to do at least one positive thing for yourself every day. So for example, this could be taking a long bath. This could be making sure that your eyebrows are looking neat and tidy. This could be reading a book. Make sure that you take some time for yourself. Some people like to create something called a Resilience Toolkit. And so this is activities that you know that improves your mood and that you could fill an actual box with things that will help cheer yourself up. I know that I did this with mindfulness things. So for example, I ensure that I had a whole heap of Maltesers. So I did mindfulness whilst eating Maltesers. I also have a thing about touching certain textures. So I ensured that some of those textures were in the box, just things that I would use to self-soothe. And also be kind to yourself. We are often our own worst critics. And if you were speaking to someone who was feeling down, and how would you react to them? You'd probably react to them in a much more compassionate way than what you would react to yourself. So keep that in mind. If you were speaking to someone who was feeling the same way as you, how would you help to make them feel better? Also, if there are times when you are feeling lonely or that you feel that you haven't got a purpose, you could consider joining a group, or you could consider doing new things, trying out something new, starting a new hobby. So for example, I taught myself to crochet as a result of my depression. You could try volunteering, and you can also ensure that you set yourself realistic goals. There's no point in setting goals that are unrealistic and unachievable because it will just make you feel worse. So think about smaller bite-sized chunks that you can achieve to get somewhere. So for example, I'm trying to lose weight. I have to lose a lot of weight. And so I split that down into half stone portions. And after I've lost half a stone, I give myself a treat that isn't food related to help me keep going in the right direction. You can also challenge your low mood. So for example, some people keep a mood diary and they can track the changes of their mood, and that they might find that certain days are more down days than others. You can also challenge your thinking. So you can question yourself why it is you are thinking the way that you're thinking. And Students Against Depression have a lot of information and activity sheets, which I will put in the show notes for you. You can try self-help and self-help books. You can also contact a helpline if you are feeling extremely low. So for example, the Samaritans are a fantastic resource. You can call them 24 hours a day and they will give you support and they will just listen to you and you can talk to them. And you don't necessarily have to be having any kind of suicidal thoughts. So statistics from the Samaritans show that only 1 in 5 people who phone the helpline have suicidal thoughts. So please bear that in mind. It isn't just for people that are thinking about suicide. It is for everyone. And if you need to speak to someone because you're feeling depressed, they're a good place to go to. There's also information that you can gather from Mind, and they have an information line. And I'll put that link into the show notes too. And I don't know about you, but when I'm depressed, I find that I disconnect with people and people around me, and I tend to move inwards. And one of the biggest things that I found helpful is ensuring that I stay connected with other people. So keeping in touch with friends, trying to talk to them, even if I don't necessarily feel like going and doing anything with a group of people. You can also join peer support groups. You can also think about online support groups as well. They can help you because it's a group of people that are having similar issues to you, and you can talk about it and you can feel like you're not necessarily alone. So that kind of concludes everything that I wanted to talk about. So I'd just like to finish off with, if you are feeling suicidal, please, please, please talk to someone, reach out and get help. Even if you feel that there is so much stigma associated with suicide and depression and mental health, really just reach out to someone that you trust, that you know will help you and not ridicule you for the way that you're feeling. Everyone has mental health problems of some description. However, when it's impacting your daily life and your day-to-day activities, that is when you really need some help. I'm going to put a load of links into the show notes for you all, and as someone who suffers from one particular mental health issue that is highly stigmatized within the medical profession, I definitely know the impacts that feeling stigmatized have, but really you've got to just say, sod it all, I need to tell someone and I need help. So thanks for listening to this deep dive on depression and suicide. If you have any questions, please feel free to contact me at hello@mentalhealthbookclub.com. You can contact us via Twitter with our Twitter handle of @MHBC_podcast. You can also find us on Facebook at Mental Health Book Club. Please look after yourselves, and we will see you next week. Bye for now. Thanks for listening to this episode of the Mental Health Book Club podcast. If you feel that you need additional support with your mental health, please call the Samaritans on 116-123, which is a 24-hour helpline. And if you need additional information about mental health issues, please visit Mind at mind.org.uk. Next week will be Autism Anxiety and Me by Emma Louise Bridge. To find out more, please visit our website, mentalhealthbookclub.com. We would really love to hear what you think about this podcast. Please get in touch with us at our Facebook page, which is the Mental Health Book Club, or at our Twitter, which is @MHBC_podcast. And if you like the podcast, please share it with your family and friends and leave us a 5-star rating on iTunes or wherever you get your podcasts.